Spina bifida. It's pretty rare these days. Don't see a lot of patients with this disorder, um, and it can vary the levels, which we will go over. Different types. Um, these are this. Oh, are still unknown, but related to folic acid deficiency during the first trimester. And this is detectable through different tests that they take, but it's I think probably every year, every couple of years, the incidence does decline. Like it's pretty rare, but it still happens. This says 1 in 1,000 births. I think it's even less now. Um, detected by ultrasound amniocentesis. Um, they can have surgery shortly after birth to reduce that defect and to close, do whatever they need to do to repair. And usually these kiddos have a shunt for hydrocephalus. So this is a pretty important aspect, and they'll have that shunt forever. This is a picture of the different types, the occulta, the meningocele, um, on to the next. So talking about hydrocephalus and the shunting, it's, as the name depicts, it's water on the brain, and a very high percentage of the children with spina bifida develop this. And it's secondary to the blockage of the spinal fluid pathways in and around the brain. It can cause brain cell death. So these kiddos are shunted at the initial surgery for prevention with tubing. It's placed in a ventricle and then goes all the way down to the stomach, and that's where it drains out. You want to pay attention to this contraindication for a shunt. This is very important if you have a kiddo, and it's your responsibility when you have these kiddos to find out if they have a shunt, and these kiddos can't go upside down because they have this shunt that's draining into their tummies. So for obvious reasons, you don't want them to be upside down for long periods of time. You also do not want these kiddos. Well, if they are complaining of a headache, nausea, throwing up, any of these types of situations could be a malfunction of the shunt, or it could just indicate time for, when these kiddos grow. Obviously, they have to go every so often and get the shunts replaced. So just pay attention to normal behaviors of these kiddos to know if something might be wrong with the shunt. So other conditions, just make sure you know these. Club feet is very common with these kiddos. Hip issues, osteoporosis, scoliosis. And then you need to know the levels of disability. These are very important. So T12 to L1, if that is the level of their I don't know what I want to say here. If this is just the level that they that is affected. These children will be in wheelchairs more than likely. Their hip flexors are very, very weak. And then as we go down in level, you can see that they will be able to function with more independence. So know these levels, know what can be expected at these levels. This RGO, you can look this up, and I think I have a picture of it as well, to see what this is. But it helps them move, helps them ambulate. There's a picture of it. You could probably find a clearer picture online. Just type it in, but it's kind of a full body, and it starts at not full body, but full trunk. So this is all brace, and then it has a system, a bracing system here that you can lock and unlock. This is a HKFO, HKFO. That stands for hip, knee, ankle, foot orthosis. So this goes around the waist, and it's adjustable. They are fitted for this. This is a custom fit, and obviously you can tell that this goes around their thigh. It's open at the knee, and it's rigid in the anterior. This goes along the shin, so this is anterior, and you have to slide them in from the back. And they should be able to use this to help them ambulate with usually a walker. It could be bilateral canes or the Lofstrands, depending on what level. Very cumbersome to get these kiddos in and out of these, but it's a good system. This is a knee, ankle, foot orthosis. You can tell because it's only going to be controlled that hinge at the knee. So again, depending on the level, the kiddo's level, this would be indicated. Trying to remember what this is called. There's different types of bracing methods now, depending on the brand. And if you look closely, you can see that you can set these in different levels of external rotation, internal rotation, or ABD, adduction, and the kiddos sleep in these, and they spend a lot of time in these to try to alter that club foot. And again, these kiddos a lot of times have hip issues too, so this helps align that hip according to the doctor's orders, and as far as the needed level or needed angle. So different interventions, range of motion, positioning, obviously depending on the level. We need to talk about their positioning in their chair, in bed, and then upper extremity strength, trunk strength, and control, mobility activities, and any type of ambulatory activities depending on their level and equipment needs. Okay, moving on to juvenile RA. That's the connective tissue issue, especially in the joints, and it usually happens early. Treatment for this is passive inactive range of motion, pain control. These kiddos are in some pain. Adaptations of equipment. Congenital limb deficiencies. We need to improve the independence and quality of these kiddos' movement. That's all I have to say about that. Arthrogryposis congenita. And you can look these up. I think I have some pictures as well, but you can look these up online to see pictures. Severe non-progressive. This is a severe joint contractures and muscle weakness at birth. We want to work on range with these kiddos, strengthening, positioning, equipment, splinting. Very important, splinting for sure. And splinting can be the use of a brace or a night splint, where we try to put them in a certain degree and keep them there. And usually the best time to do this is at night or during a nap. Oh, here's a picture of the arthrogryposis. These are examples. So you can see why splinting would be important for these kiddos.